Okay, so then the shoulder slash, so the shoulder or the glenohumeral joint. So this has the greatest range of motion and it's the least stable joint. Well, think of it this way, like if you have, maybe I'll do this later on, but things that this is kind of trade-off. The more stability you have in the joint, the the less flexible it is. So it's like if you have like, or if you ever lived in like a very cold place, what happens when you put on multiple layers of clothing and wrap yourselves in many different layers? Well, thing is that sometimes you notice it's kind of hard to move, especially if you're like, if you've grown up in a very cold place. Like you've seen those little kids where they're bundled in like 5 layers and they can only move like this when they're walking through the snow. So again, the more layers you're wrapped in, the less flexible you are. Joints are kind of similar. The more you wrap them in, the more stable it is, but less freedom. The opposite is also true. The more freely movable the joint, the less stable it is. So the thing is that the shoulder joint in most people is typically the most flexible joint, but it's also the least stable joint. So again, this is why I said if you're going to PT or occupational therapy or anything orthopedics, or especially when you go to PT or PTA, I mean, you're probably going to get at least one person who has some sort of shoulder injury. So the things that the good thing is that it's not only supported by tendons and ligaments, but also skeletal muscles as well. So the thing is that ball and socket diarthrosis, so the synovial joint and ball and socket, this is the one that has triaxial movement. Again, the shoulder joint can move in 3 dimensions. That's the maximum amount of axes you can move in. So the thing is this, again, glenohumeral joint. All right, so let's cover this. So again, remember, this is the acromion, right? So the acromion, the point of your shoulder, the coracoid process in the front, or actually rewind a bit, and that's on the glenoid cavity, right? So the glenoid cavity, this is where the head of the humerus fits in. And then in front of the acromion, you have the coracoid process, right? So again, these parts are very important, but why are they very important? Well, they're very important anchoring many of the ligaments and tendons that stabilize the shoulder joint. So here are the shoulder ligaments. So here we have the acromion, and here we have the clavicle. What should we call that ligament? Maybe we should call it the acromioclavicular joint or ligament. So again, and then how about this one? Between the coracoid process and the clavicle, what should we call that ligament? Maybe we should call it the coracoclavicular joint. Oh, how about between the coracoid process and the acromion? Maybe let's call it the coracoacromial ligament. So this is why joints are like, oh man, this is so systematic. I love it. And how about the glenoid cavity and the humerus? Well, you have a glenohumeral ligament. And how about between the coracoid process and the humerus? Well, you have a coracohumeral ligament. Again, so what I'm getting at here is that all these bone markings and all the ligaments that span these bone markings or connect them to the humerus and to each other, this helps to stabilize the overall shoulder joint. Okay, let's do a quick break and a top hat question. And this might be a review to if you were here last lecture. All right, get ready. So name any one rotator cuff muscle. Okay, so again, that was a big hint right there. So again, that image right there, you saw that there were all those parts. So these are your rotator cuff muscles. And again, why do I make such a big deal about this? Because those muscles are involved in not only in terms of like, not only do they make up your rotator cuff, but notice that they're all kind of wrapping around that glenohumeral joint. So that's why when typically you have a rotator cuff injury, you want to kind of strengthen those muscles as well. And again, this is why I provide that picture, because again, look at 3 of the 4 rotator cuff muscles. They're named after bone markings. So all you had to do is like chop off that part that says something fossa and just kind of Latinize it and make it either ATIS or ARIS. So again, just ends with US or IS. So again, this is why you have to know some of these markings. And the lateral border, again, that was kind of tricky. The teres minor is that exception where there's no lateral bordoralis. It's just the teres minor. And what did cover this? So the thing is that, again, those rotator cuff muscles, they help to stabilize that overall glenohumeral joint. You also have something, but things that, is it just muscles? Is it just ligaments? You also have something called the glenoid labrum. So this is a ring of fibrocartilage, and what does it do? It deepens the socket of that glenoid cavity. So you do have that glenoid fossa or glenoid cavity in the scapula itself, but you also have a ring of fibrocartilage that helps to make that socket a little more deeper. So it's a fibrocartilage lining and it extends past the bone. So again, it's more than just the fossa of the actual scapular bone itself. So here's the glenoid cavity, aka glenoid fossa, and this glenoid labrum. This is a ring of fibrocartilage. Again, fibrocartilage, that's collagen-rich type of cartilage that's very structurally strong. And so look at this, like a lot of rotation there. So again, this is the most movement of all the joints in your body, unless you have a really flexible dancer with your hips. But again, in most people, your glenohumeral joint is the most flexible joint. So what type of shoulder injury typically ends a pitcher's career? Again, look at this pitcher. They not only have to have a lot of flexibility, but they also are like doing a lot of mechanical stress and force when they're whipping a ball at 100 plus miles per hour. So the thing is that there's something you might have heard called a slap tear. So what's a slap tear? Well, it involves this glenoid labrum. So it's called it's an acronym. It's like superior labral tear from anterior to posterior. So superior again, upper part right here, and anterior to posterior. So this is why we have a slap tear. So what happens again is superior part, not this part that's inferior, and it runs from anterior to posterior. So this is what happens is that this kind of like fibrocartilage ring becomes a little unglued, and therefore if it's like that, it's not going to fit the humerus as well, and that's also going to be pretty painful as well. So the slap tear never quite heals like how. So the thing, why does it typically end the pitcher's career? Even though it can heal, it never quite fits the same way. So maybe they're no longer pitching at those very high speeds as they were when they were at the prime pre-injury. So the thing is that labrum, it's a ring, but it's very important to the overall stability of your glenohumeral joint. Now you have the elbow joint, so there's superior supporting structures of the elbow. You have the muscles, and again, it's not just ligaments, not just tendons. Sometimes muscles themselves help to the overall stability of a joint. And then we have the elbow ligaments, and then we have the radial collateral, annular, and ulnar collateral. So what we have here, now there are many ligaments in this picture, but what I want you to focus on are these. So whenever you have these collateral ligaments, lateral, again, when you have lateral and anatomical directions, that means to the side, right? So whenever you have a collateral ligament, so remember the word co is like when you cohabitate, you're living with someone. When you cooperate, you're working with someone. So when you have a collateral ligaments, typically there are two different ligaments, but they work together to help stabilize an overall sort of structure. So the radial and ulnar collateral ligaments, they work together on different sides to help stabilize the elbow joint. And then you have an annular ligament. Again, remember that root word annulus, or something that's annular, is ring-shaped. And where do you notice it's fitting around? It's fitting around that circular head of the radius. So what is actually a ring of dense connective tissue that the head of the radius can rotate within. So that's why it's ring-shaped. So what's another part I want you to know for the elbow joint? This part right here. So we're seeing the lateral view, a side view of the right elbow, but what we have here is a little point right here. So you know it looks kind of reversed here, but what we have is the lateral epicondyle. So again, lateral because it's on the outside. And why do I point this out? Well, there are many tendons attached to that. And when you hear that term tennis elbow due to some repetitive movement and stress to this elbow joint, well, this is why it's typically also known as lateral epicondylitis. So it's the inflammation and pain in that lateral epicondyle and the associated tendons and structures that attach to in that area.